Hello, and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss varicoceles, a condition found in 15% of men that can cause both pain and infertility. In fact, varicoceles are found in 35% of men with infertility. But what exactly is a varicocele and what causes the condition? How do you know if you have a varicocele? Do all varicoceles need treatment? And how are they treated? And what are the outcomes? To answer these questions and many more, we turn to a true expert. Dr. Mary Samplaski is the Associate Professor of Urology and Director of Male Infertility, Andrology and Microsurgery at the University of Southern California. She earned her medical degree at George Washington University and went on to complete her residency training in urology at the Cleveland Clinic. She then did a 2-year fellowship at the University of Toronto. Dr. Samplaski is routinely invited to speak as an expert at both domestic and international conferences. She's received numerous awards and accolades for her academic accomplishments, including the prestigious Bruce Hubbard Stewart Award for Humanistic Medicine. She is a reviewer for over 10 major urologic journals. And now, without further ado, I bring you a conversation with Dr. Mary Samplaski about varicoceles. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about varicoceles, a condition that affects approximately 10 to 15% of all men, and a condition that can both cause pain and, in some men, infertility. But how do we know if we have a varicocele? And how do we know if we need to treat it? And if we do need to treat it, what are the treatment options available? In order to answer these questions and many more, we are very lucky to be joined by a true expert. Dr. Mary Samplaski is an associate professor of urology at USC, and she's also a specialist in infertility. Dr. Samplaski, welcome to the program.
Thanks for having me.
It's a pleasure. It's a pleasure. Before we jump into the topic at hand, I'm sure the guys would love to know a little bit more about you and specifically kind of why you chose the path of urology and even more specifically, helping men with infertility.
Everyone has their own sort of unique path. I would say I did not always know I wanted to be a urologist or a fertility expert. I started out thinking I was going to be in general surgery. I would even say before that, I wanted to be a marine biologist, as many like young people do. And at some point I discovered medicine. I liked procedures. I liked the OR. So I was sort of on the general surgery path. Then I did a urology rotation, and I was really, I liked the people. Urologists tend to be very nice people. It appealed to me the concept of being very good at one system instead of being a little bit more jack of all trades. Mm-hmm. So I applied for urology. That was sort of the main reasons. And then for infertility, again, I sort of started the whole thing thinking I was going to be doing bigger cases. I thought I was going to be like doing cystectomies. Like I really liked operating. We did a fertility andrology rotation, and I just thought it was so incredibly interesting. And I still do. I think what we do is so cool. The genetic aspects of things, the Klinefelters and the Y chromosome microdeletions, and then, to be honest, there's probably like thousands of other genetic abnormalities that we don't even know of. And that also is super appealing to me, the fact that fertility and andrology is a young specialty. And I think there's so many sort of things that we're going to learn and discover in the next, during my career. And then the very core of it all, it's a beautiful thing to help couples have kids. I mean, to see, I always tell couples it's not cancer. It doesn't have the same life and death sort of consequences. but we make a difference in people's lives in like a very big and beautiful way. And so that's why I find my job meaningful.
That's wonderful. You bring a lot of happiness into people's lives, I'm sure. To be able to give them something they so desperately want is a magical thing to get up in the morning for and say, I'm gonna provide that kind of joy to a couple is fantastic. And I'm sure they're very thankful for the work that you do. So I'm sure that, given how common varicoceles are, I'm sure you see them quite frequently in your practice. But we're going to start at the very basics. What is exactly a varicocele?
Yeah, so varicocele is dilated veins that drain the testicle, and its most like simplistic form. So I think of it almost like varicose veins that you see in your legs. But the thing with the testicle is that it's really so mobile, and it doesn't really have a whole lot of muscle backing. And so sometimes the veins that drain the testicle, which when you think about it, are going directly against gravity, they're going straight up.
Sure.
Um, and so the plumbing is going like directly against gravity. They don't have a whole lot of sort of structure to support that sort of scaffolding. And so those veins in some guys have a tendency to dilate. And when they dilate, sometimes they don't drain properly. The small valves that are within veins don't sort of kiss each other. And then you get a pooling of blood around the testicle. And that pooling of blood, and it's oxygen poor blood, it's the blue or the oxygen poor blood. That blood can cause too much heat. It can cause a couple of other things that can sort of hurt fertility potential, or cause discomfort. But it's basically dilated veins that drain the testicle.
And it's pretty common, about 15% of men just overall. So these 15% of men generally have that valve issue that causes that doesn't allow the veins to drain properly. Is that about right in terms of a cause?
Yes.
Got it.
Yeah. I mean, there's a couple sort of, that's the sort of plumbing side of things. But then when you think about it, the blood that pools, it's oxygen poor blood. So it's not like the healthy red blood. And then on top of it, there's a couple other theories that sort of for why that blood in particular is not good. So the heat is the most common, that those testicles are a little bit warmer. Testicles live outside the body because they like to be a little bit cooler than structures inside the body. But then there's also free radicals. There's also the thought that because adrenal gland is sort of tucked up in the body upstream, but that you may get some reflux of adrenal metabolites. But basically sort of free radicals and bad stuff sort of pooling around the testicle, in addition to the heat that we think may sort of add up in some people to sort of causing a not optimal environment for sperm production, and for some people sort of causing discomfort.
Got it. Now, a lot of conditions we discuss on the program, we talk about predisposition, genetic risks. Do you know of any, or are there any predisposition or certain men at higher risk for varicoceles, or it's just luck of the draw, basically?
It is mostly luck of the draw. There's been a couple studies looking at, does weight play into it to any degree, or sort of people who are a little bit heavier, does that cause more back pressure onto the veins? And I would say not necessarily. It is a little bit sort of luck of the draw.
Makes sense. And in the same vein, I'm assuming that varicoceles in that sense can't really be prevented, right? I mean, it's nothing you can do to prevent yourself from getting one, basically.
Not really. As opposed to varicose veins in your legs where you can wear compression socks, there's not really a whole lot that you can do to sort of control whether this is going to happen to you.
And so, as I mentioned at the beginning program, it's a pretty common condition, 15% of men. Do all those men that have varicoceles, do they all have symptoms from it? Do they all know they have it?
No, it's interesting because a lot of people don't. I see a number of people who just sort of say like, yeah, people are not made symmetrically. And I thought this was just sort of normal. And the reality is, if it's not bothering you, you don't have to do anything about it. But a number, no, there's to answer your question, a lot of people don't even realize that it's there.
And when it does cause symptoms, you had mentioned pain before. Can you help us understand like what kind of pain they might feeling or symptoms, or do they see something there that might say, hey, I might have a varicocele?
So yeah, the main sort of things to think about is discomfort. It's usually not, people usually say it's not severe enough to cause pain, but it's discomfort. And the word is usually achy, achy sensation, and worse typically at the end of the day because people have been upright and walking. So there's more of a pooling effect. Sometimes people will say it's worse after heavy lifting. I've had some people say it's worse after taking long showers. And then oftentimes people say it gets better when they're laying flat.
Got it. And do they also, I mean, aside from the pain, do they see anything there? Is there like swelling or something they should expect to see? Does it feel any different than a regular testicle?
Some people will notice that they can see the veins. So I've had definitely some people say, yeah, I just thought this side was like a little bit different. And I think visually, the varicoceles and by palpation, they come in, we call it small, medium, and large, or I call it small, medium, and large, but different grades. There's a grading system, grade 1, 2, and 3. 3 is the biggest. And when you see a 3, you can see it with your eyes. And it almost looks like little gummy worms under the skin. So you'll see, it's classically described as a bag of worms. And it really does sort of look like that. You sort of, if you pull the skin a little bit over the spermatic cord, which is the rope that connects the testicle to the body, you'll see these sort of dilated veins structures. For some people, and I will say there's been a number of times that I examine somebody, and when I show them and I'll say, see, you can see on one side, you can see this, and on the other side, you don't. They say, oh yeah, I guess you can. But oftentimes, unless if people are really doing a little bit more of like an in-depth self-exam, sometimes people don't know that they're there. The other thing that these dilated veins can cause is they can cause what we call atrophy, which is where one testicle gets a little bit smaller than the other because the environment for growth is not optimal. So that's one of the things whenever we sort of get imaging or when we're examining people that we want to check is, are the testicles symmetric in size? Like, are they both about the same? Or is that extra heat or, the different mechanisms that varicoceles cause damage, is that resulting in impairment of growth of the one side?
Got it. So we've talked about 3 potential consequences of varicocele. You just mentioned decreased growth. We talked about infertility, which we're going to spend the vast majority of the time of the interview on, and then also pain. If somebody has a varicocele that causes pain, just to give it some attention here before we go on to the infertility part of it, and the infertility is not at play, it's not an issue. Are there any things like conservative things that people can do to decrease the pain of a varicocele, to just keep it under control?
I've had I will usually suggest that people try more snug underwear. There's no peer-reviewed studies showing this, but I tend to sort of save surgery as sort of the last step. And if you can sort of find ways around it, do that. And, for some people, the snugger underwear have helped. I would say for the most part, it has not been like immensely successful, but every once in a while somebody says, yeah, that helps enough where I don't want to have a procedure. And great, then you saved yourself a procedure.
Got it. So varicoceles and infertility. First of all, we mentioned that 15% of men have varicoceles. Is it safe to say that not all of them will have infertility problems, or how does that break down in terms of those men with varicoceles and infertility, or do we know?
Yeah, so about half of guys with varicoceles will have fertility issues, but what I tell people is that means half don't. So I will say some of the biggest varicoceles that I've fixed have been from people who have kids. So, I mean, we know not all varicoceles cause fertility issues. So it's about 50-50. And sometimes that can be if somebody has seen it, let's say somebody's seen it in the shower, and they come and they say, well, I've never tried to have kids. I've never had a semen analysis. What should I do? How would you guide me? And that's a little bit of gray area. And I've definitely had a number of people, if they're not having symptoms, who will check a semen analysis and use that to sort of guide their decision making. If everything looks normal, they sort of will just wait on any procedures and sort of try once they have their partner. I forgot the other part of your question.
Well, no, actually, that was a good one, but I want to break that down for some. So that's some interesting scenarios. So let's go through a couple scenarios. The first scenario you mentioned is a guy who has children, has had no problems with conceiving, and just notices, hey, I've got a large varicocele. That's not symptomatic. Does that guy need any type of treatment for that varicocele per se?
I personally would not. The one caveat is that now there are some series showing that varicoceles can also hurt testosterone production down the road. So basically, testicle has two main jobs: to make sperm and to make testosterone. And so now there are some theories showing that fixing varicoceles can improve testosterone production down the road. So does it delay the need to be on testosterone replacement, or negate that need altogether? So I think that is still sort of an area of active research. It's I would not say that that's like sort of standard of care yet, but it's something to sort of put in the idea bin and to consider when you're sort of considering how to manage these.
The other scenario you mentioned is, again, a guy, no pain, notices in the shower, hey, I got these gummy worms above my testicles. That's not good. And you know what? Maybe they're 25. Maybe they're in a relationship or not even in a relationship. Kids are not even on the horizon yet, but they're like, hey, down the line, I've heard that this is associated with infertility. 50% have it. You mentioned getting a semen analysis. Is that pretty standard recommendation, like just to make sure, or is that more for like patient comfort or peace of mind, do you think?
It's not standard of care. It's a lot for patient comfort. For some people, and I can totally understand this, it's knowing that there's sort of something abnormal is difficult to sort of just like live your life with. Some people have no problems with that.
Right.
But there is, when a patient gets back on totally normal semen analysis, they're so happy, and it's just such a sort of sigh of relief. Flip side to that is if there is something abnormal, there's sort of this like opportunity for intervention. But that brings us to like another fork in our decision tree. Is it better to fix them earlier versus later? And we don't know the answer to that question.
Well, that was going to be my question. So like, even take it even worse than that, right? Or better than that, I guess. Let's say, again, another example, 25-year-old guy has a varicocele, checks the semen analysis, is totally normal. Okay. What patients will ask would be, is there a chance that even though I'm 25 now and my semen analysis is normal, if I don't fix the varicocele 5 years from now, 10 years from now, when I'm ready to have kids, then it'll be really abnormal because the varicocele is causing ongoing damage? Is that, you think, a legitimate concern based on data, or do we not have enough data to support that?
I think we don't have enough data to sort of guide people one way or the other. I do have a few patients who every year will check a semen analysis to sort of try and get an idea of like the trajectory of their parameters, right? To see, is the sperm count declining? Is it staying about the same? I would say for and we're talking like maybe 10 or 15 patients, I think they've all sort of stayed stable, which for me is quite reassuring also. But we just don't have enough data, like big series following guys with varicoceles, to know if fixing them earlier creates a better environment that is preserved versus sort of waiting until they're ready.
Got it. And by waiting until ready, meaning that when they're ready to have kids, they just try. And if they have kids, fantastic, no need to worry. And if they don't, then we start dealing with the varicocele. Is that correct?
Yeah. And then, the other piece to the fertility discussion is always the female, because, you never, if the guy's really young, and some of this is sort of cultural or sort of what they were raised with, but some people plan on getting married when they're 24, 25, 26. I mean, good chances they're going to have a young female partner with great ovarian reserve and good egg quality. For people who are sort of, a little bit later in life, there's a good chance that the female egg quality isn't going to be that great anyhow. And so they may end up sort of needing help on the female end. And so you sort of like factor all, at least for me, I end up factoring all of those things into our discussion, because obviously having a baby is not just having good sperm, you have to have good egg.
It's a two-way street, right?
Yeah, there's multiple things that go into it. So I mean, you can have like A+ sperm, but if there's no egg that's being released, or if the egg quality is not that great, or if the uterus is off, it's not going to happen. So there's so many layers to like the fertility discussion. But I tend to, if they're not having symptoms and their semen analysis is normal, I mean, I offer them to check once a year. Some people do that. There's a great deal of reassurance for most people in doing that, but I tend not to sort of push them to fix it early, because there's just not enough data, I think, to sort of support that.
So that's actually fantastic to hear, but I want to take a step back. We keep mentioning semen analysis, and for you and me, this is great, but for all the listeners, they may not be fully hip to that, right? So if you can, aside from varicoceles, if you can just give us a high level, what is a semen analysis, and specifically when you're looking at it, what factors are you looking at to assess if a man is, what the potential for fertility is in a man? Let's put it that way.
Yeah. So semen analysis is our best test to assess male fertility potential. It's definitely not a perfect test, but it's sort of the best test that we have. Essentially, guys make a sample into a cup, and a lab looks at that sample under a microscope. And the things that they're looking for is the volume that's produced. So how much comes out. If people have had some kind of either surgery on their penis or on their urethra, or some kind of pelvic surgery where nothing comes out, there's no like vector for the sperm to make it out of the body. Sperm count, super important. Sperm count or concentration, sort of different variations of the same thing. That's the number of sperm. And a normal, according to the most recent WHO guidelines, is 15 million sperm per milliliter. But there's a wide range of sort of what people can sort of have. Motility is how those sperm are swimming. So sperm got to swim to the egg, and we break the motility is actually broken up even further on these reports. If patients ever have access to the report, they usually break it up into the fast swimmers, the slow swimmers, the ones that are moving. So they're showing us they're alive, but they're not sort of moving in a forward direction yet. And the non-motile ones, which can either be dead or have something wrong with the swimming capability where they're not sort of moving forward.
Got it.
And then the last sort of section that we look at is the morphology. And morphology is sort of the shape of the sperm. Do they have a normal head? Do they have the enzyme cap that sort of bores through the egg? Do they have the neck? Do they have a tail? Do they have sort of one of each? Do they not have a lot of these cytoplasmic droplets? How do they look under the microscope?
And so in looking at all of this, does a varicocele have a specific pattern of problems that you see on a semen analysis, or is it just pretty generic?
So the varicoceles typically cause what we call a stress pattern, but basically it's lower count and lower motility, and then lower morphology. So the volume is a little bit, I think of it like a plumbing sort of factor. So as long as the plumbing is okay, that's not going to all be changed, but it can affect all the other sort of aspects of the standard semen analysis. The other thing, not to go too far down this rabbit hole, but there is a little bit of, there's actually more than a little, there's this concept of the sperm DNA health and sperm DNA integrity. This is a separate test from the standard semen analysis. This would be something that would be done in conjunction with like a reproductive urologist. But essentially, when you look at the sperm under the microscope, you're getting like what what somebody sees under a microscope, but it doesn't tell you anything about the genetic health of the sperm.
Hmm.
And varicoceles have been shown, especially the bigger ones, to, in some people, hurt the genetic health of the sperm. And I think it's super important to note, if that, if you end up having that test done and it's abnormal, it doesn't necessarily mean you're going to have sick babies. Usually what that means is sort of higher chances of miscarriage. So, in effect, varicoceles can not only affect just how the sperm look under the microscope, but the health of the sperm.
And do certain patterns on the standard semen analysis trigger you to order that specific DNA test, or that's a pretty routine thing you do for everyone?
I don't do it for that many people. Usually the DNA test I only do if people have had sort of recurrent miscarriages, number one. If they've done fertility treatments such as IUI or IVF and things haven't worked, when everything's sort of on the female end seems normal. Sometimes to guide decision making. Sometimes if people are like right on the fence about doing varicocele surgery and they're so like unsure. And then people who, the other sort of subgroups that I'll sometimes order it on are people who use SSRIs, depression medications, because those have been shown to alter the sperm DNA. This is independent of varicocele, or people with cigarettes, marijuana, things that we know can sort of alter the sperm genetic health.
And one last question about semen analysis before we go on. A big frustration that guys have is that they're sometimes told they do it wrong in terms of the semen analysis. Are there certain, as a fertility specialist, do you give certain guidelines or recommendations about how to collect the sample, what needs to be done?
Yeah, it can be really stressful for guys. It's, it's not like a natural experience. As much as possible, I try, and if people can make it at home, and this is super variable among clinics, among like hospitals. But if they can make it at home, if they live close enough to the facility, I think that's fine. The sample has to be processed within, they say, an hour. I tell people to like try and get it to the clinic within 20 minutes if you can, because account for it to like get passed off to the person who works up front and then sit on the counter, and like hopefully nobody takes their lunch break, and all the things that happen once you hand the sample off. But in general, we tell people 3 to 5 days of abstinence. You don't want to do it back to back after you've released or ejaculated, because say you ejaculated on a Monday and you make the sample on a Tuesday, the sort of reservoir is going to be empty. So you're going to get an artificially low number in terms of the count.
Got it.
So starts to fill up around day 3. After about day 5 to 6, you start to get a higher proportion of dead sperm. And so then the motility starts to look artificially low, because living sperm swim. And if you get, if people haven't released in like 10 days and then they make the semen analysis, the count's going to be really high, but the motility might be very low because you're getting a very high percentage of dead sperm.
Interesting.
But otherwise, the other things I do, because it is, it's like I said, it's just not like a natural experience. It can be super anxiety provoking. I give guys 2 cups. The number of times people say like, oh, I was, I made the sample and then the cup fell over. So just, and like, then, everybody, they're like ready to go. They've got the window, the car's ready. They're like, they know where they're going. And then to have the cup tip over and then have the specimen either drip out, like it's, or like, then they're worried it's contaminated with bacteria. So I give guys 2 cups. I always just sort of say, like, if it doesn't work the first time, like try again in a week, and try and just sort of make it like, because it can be done in a week later, and try and minimize the sort of gravity of doing it in that moment.
Yeah, it could definitely be very stressful, but that's good advice. And that's interesting about that sweet spot of 3 to 5 days really is important. So let's say a guy either notices an asymptomatic varicocele, or maybe he's having fertility issues, and he says, I should really go see a doctor. One thing guys really are nervous about are going to see a doctor, because a lot of it is they really don't know what to expect, what kind of probing is going to be happening, what's going to be going on there. So one thing I like to do on the program is just to walk them through it, like what to expect. So if I have a varicocele, again, whether I have infertility or I'm not sure I will have infertility, and I go to Dr. Samplaski and I say, you know what, help me figure this out. What should I expect in that visit to you?
Yeah, it is. You were right. Guys are so, it's guys get nervous. I mean, I think anybody gets nervous because you never know what you're going to find.
Exactly.
So at the beginning, it's a lot of talking, a lot of just sort of going over reproductive health or pain, or trying to figure out why they sort of think that there's something there. For varicocele, there is an exam. It's the way that we're supposed to diagnose these, specifically for fertility, is with a physical exam. We're supposed to only repair varicoceles that are seen on physical exam, less of the ones that are found on ultrasound. So usually what I tell people is, we're going to examine your testicles, size, shape, consistency, the connections, and then look for those dilated veins. So basically trousers or pants and underwear down. I will say the one thing I tell people that I think is reassuring is nobody likes a rectal exam, and we don't need to do a rectal exam looking for varicocele. Certainly nobody enjoys like the testicular exam, but it doesn't hurt. It's not like super invasive.
Right.
And they also get like a built-in testicular exam to rule out cancer.
Sure. Well, that I think that most guys would take a testicular exam over a rectal exam. That's for sure. So aside from the physical exam, you mentioned ultrasound. Is ultrasound something standard that's obtained in everyone that's with varicoceles?
So per the practice guidelines, you don't need to perform ultrasound in everybody. Sometimes patients want it. The problem is there are plenty of times where there's like a decent discrepancy between what the ultrasound tech finds and what the urologist finds. And some of that is because sometimes, usually when we are checking guys for varicoceles, I'll have them bear down or cough, something to sort of cause back pressure to make those veins dilate. And sometimes when the ultrasound techs are doing the exams, they don't sort of capture that moment when the veins are maximally dilated.
Got it.
So most guys don't get an ultrasound. The groups that do, that I'll send, are people that have difficult exam. There are some guys who have sort of a snug scrotum where I can't really get you can't really get a good feel for if those veins are present due to sort of just a snug anatomy. People, there's like any kind of concern for mass, if there's anything that feels a little bit off in terms for the testicle. Or if one testicle is sort of smaller than the other, and you're wondering, is this really smaller, or is this just sort of, you're questioning whether there's something on your exam.
Got it. And we talked a lot about semen analysis, but are there any other labs that they should expect outside of that?
Well, some of it depends on what they're coming for. If they're coming just for varicocele, not for fertility, then usually not. If people are coming for varicocele plus fertility, they're trying for a baby, then we sort of get into the semen analysis, and sometimes we'll do a hormone panel. But if they're just coming for varicocele, you don't need blood work.
Got it. So we talked a little bit about the considerations about whether to treat a varicocele or not, and we talked about the different scenarios. Let's say, I'm in your office, I have a varicocele, you've counseled me as we discussed, and it's a good idea. Maybe I have infertility, maybe my semen analysis represents it, and you say, you know what, I'd recommend treatment. Generally speaking, before we dive in, what are the treatment options on a high level for somebody who has a varicocele?
The two main treatment options are surgery versus embolization. Surgery is sort of surgery. Most people you go to the OR, we'll sort of take a deeper dive, but you go to sleep, you get a general anesthetic. Embolization is, I tell people, it's sort of accomplishing the same thing by a different route. So that is done by the interventional radiology team. So it's not something that urologists do. So you'd have to go see a whole different team of doctors, but they basically block the blood flow in those dilated veins from the inside of the vein by either placing a plug, like a foam plug or a coil plug. But I think of it almost like a little umbrella where they've got a little probe, they advance it through the lumen or through the tunnel of the vein. And then once they get in the one or two dilated veins, they sort of deploy their little umbrella. It's not really an umbrella, but blocks the flow of blood. And so it blocks the flow from the inside versus from surgery where we tie it from the outside.
So what is again, let's cover embolization first. So by putting in that umbrella or that plug, it blocks the vein. So what does that do, like from a, I guess, outcome measure? It kind of prevents the blood from pooling. What does it do exactly?
So if the blood is not, so basically, blood will drain via the path of least resistance. So it's going to take the big floppy veins as like their sort of preferred route. But if you tie off or block the blood flow through those big floppy veins, then the blood is going to be forced to drain through the healthier veins where those little valves are kissing each other, coapting, and where the blood is draining properly. So I almost think of it on a very sort of basic level, like blocking off a street that has like a lot of potholes. Like the cars will eventually make it home. They just have to take a different route.
Got it. Well, that's actually a good analogy. So you're basically blocking off the bad routes, keeping the good routes. And how do they know which ones are good and bad if they're going through the veins themselves? Do they shoot some dye and see which ones are more dilated? How does that work?
So at the very beginning of the procedure, they take a couple x-rays where they squirt some dye, and then they have their sort of target veins.
Got it. And for embolization, is there any cutting involved, or they just stick a needle into a vein and it goes through there?
It's all, in my understanding, and I've never sort of done one of these because I'm not a radiologist, but based on procedure notes, it's all, there's no cutting. People still get an IV anesthetic or an oral, not an anesthetic, a sedative. They get anesthetic too, so they get something for discomfort. So like they don't feel anything. And because it takes a few hours, they usually get something to sort of help them relax. But there's no cutting. And for some people, that is a huge advantage.
Got it. And obviously you counsel people all the time on surgery versus this embolization. If you're talking about embolization specifically, what risks do you usually share with the patient in terms of what they're signing up for?
So the risks are pretty much the same for surgery and for embolization, which is super interesting. They're both very low risk procedures, but infection, bleed. I always tell people there's a chance we won't make you better. That's not what we want, but I can't promise you that your pain or your fertility is going to get better. But obviously we don't do the procedure unless if we think that's what's going to happen. There's always the risk of arterial injury. So this is sort of, I tell people this is the most serious but least common. So arteries are how the testicle gets its food. That's the healthy oxygenated blood. Testicle needs that to sort of make sperm and to make testosterone. That's its sort of food supply. And so whether you do surgery or whether you do embolization, there's the risk that the artery could be injured. And the worst version of that is that the testicle would die. Now, again, this is a pretty rare event, but it's definitely on the risk sort of panel. And interestingly, the arterial injury rate is about the same for surgery versus embolization.
Interesting.
And then the last risk was called a hydrocele. Hydrocele is basically, we think that one of the lymphatics gets injured. Lymphatic is part of your body's immune system. It's how your body shows itself antigens that sort of say this belongs to me, or this is sort of something from the outside. And lymphatics look almost like water. And so it's you can injure them and sometimes not realize it. It's not like blood where you can see it pooling with your eyes because it looks like water. Sometimes you don't realize it like in the time of the OR or at the time of embolization. So what that would look like for the patient experience is that after the procedure, maybe a month later, you'd start to get a pooling of water around your testicles. So one side would be maybe the size of a apricot, and the other one might be the size of a lemon. And then you do the ultrasound, and you would see water around the testicle, and that would be what's called a hydrocele.
And that could be treated also.
Yeah, unfortunately, it's another procedure, but
Hmm.
yeah. So, we always, and I'm more familiar with the surgical end, but we're always so careful to try and sort of not poke anything that might cause people issues down the road.
Makes sense. Now, understanding that you don't do the embolizations themselves, but just to be complete here, notwithstanding people who already have pain ahead of time, like from the varicocele itself, are these embolizations a pretty painful procedure, meaning post-operatively, do people have a lot of pain? Do they need a lot of recovery time or anything?
No, the patients who I have sent for embolization come back and they're pretty happy. I would say the surgery patients are also pretty happy. And there have been studies looking at sort of post-operative recovery. And I mean, it's definitely a little bit easier for the patients for the embolization. I mean, there's almost no narcotic need. But it's sort of like, do you take like 2 days off of work or 4 days off of work?
Mhm.
And so by a week, those results are pretty much equivalent.
Got it. Got it. Okay. So let's take a turn from embolization. Let's go to surgery, which is your bread and butter when it comes to treating varicocele. First of all, in terms of surgery, what are we doing? You mentioned we go to the operating, you mentioned the general anesthesia, but what's actually happening during the surgery?
Yeah. So basically, we're tying off those dilated veins. So for what we do is most people get a general anesthetic.
Mhm.
And we do that mostly because the whole surgery is done under an operative microscope.
Mm.
Not always, but for most fertility trained people, we do it under a microscope.
Mhm.
And we do that because then we can see it, like we really can see. So it minimizes the chances of an arterial injury and the hydrocele. And it really allows us to see which are the dilated veins so that we're tying off the correct things. The flip side to this, if the patient's awake and they're sort of like shifting around and we're
Mm.
working under the microscope, I mean, that looks like an earthquake. And so people gotta be like pretty still.
Mhm.
And obviously then that impacts the complication rate, right? Because if people are really still, we can like tie off those veins and not have very little fear of injuring the artery or causing a hydrocele. So they go to sleep. The actual cut is on your groin, so it's not on the testicle, it's not even on the scrotum. It's almost where you would think someone would have a hernia cut.
Mhm.
And for most people, the cut is about a centimeter to 1.5 centimeters. If people
Mhm.
are a little heavier, sometimes it has to be a little bit bigger, or if they've had prior groin surgery, sometimes it has to be bigger, but it's pretty darn small.
Mhm.
And so through that cut, we bring up the rope that connects the testicle to the body, or the spermatic cord. And then that's when we, under the microscope, we determine if every structure in that rope is an artery or a vein or something else. And
Mhm.
the way we make that distinction is with an ultrasound. So we have
Mm.
the tiniest little microsurgical ultrasound. It's got a 2 millimeter tip. So it's almost the tip of the ultrasound is the size of like a pen. And
Mm.
you can hear whether the blood is flowing to the testicle, which would be artery blood. So when we hear that, we say like, don't touch it.
Stay away from that, right?
Yep. And then if you don't hear artery and you hear vein flow, especially if they look nice and big and juicy, those are the ones that will sort of free up and tie off.
Got it. And just a question I know guys would ask: if the gummy worms are right above the testicle, why is the cut so much higher?
So I think of it almost like a tree. And so we're going at like the trunk of the tree.
Hmm.
So if you go at and again, this is my oversimplification, but I think it illustrates the point. If you're going at the trunk of the tree, you're getting the root of those multiple veins. The
Hmm.
other thing is, doing it higher up has been shown to just have lower complication rates, just
Mm.
because there's like less poking around in like the small stuff. You tie off the root of a couple of big veins and you sort of take care of the root issue of the problem.
No pun intended. So, and how long does a varicocelectomy usually take?
60 to 90 minutes. They're pretty, in the world of surgeries, they're pretty quick.
And people go home the same day, I'm assuming.
People go home the same day. People ask these questions. There's stitches, but they're below the skin. So usually you don't have to come back for like stitch removal. I personally use skin glue. I think most people do. So in terms of sort of cosmetically, things heal up pretty darn well. Like you can usually, if you really look, see like a very faint white line, like 6 months down the road. But yeah, that part is, you don't have like big stitches sticking out of your skin or anything like that. Most people, I would say about 80% use ibuprofen alone for discomfort. It really, because the whole thing's done under the microscope, it really is like, there's not a whole lot of sort of tugging on patients' muscles or cutting muscles or cutting like strength layers. So discomfort wise, it's usually not too bad. So I tell people snug underwear, ice packs, and ibuprofen. And every once in a while, somebody needs like a little bit more, like a Tylenol 3, but it's pretty unusual.
Got it. And often questions, when can the people usually go back to work?
It depends on what they do. It's for people who do remote working, people who have mostly a desk job, I tell them to take 3 days off of work. And then if you can go back, if your job is such that like you can have flexibility to just sort of accomplish tasks at your own time, that's great. If if there's a lot of Zoom meetings, maybe like cut those down in terms of quantity, because if you're having a bad day, you might want to sort of just like lay down for a little bit. People who have jobs that involve heavy lifting, so drivers or delivery people, I really like them to be off for like 2 weeks. It's just, the recovery is so smooth when it goes smooth, and people get so nervous when like something happens, like when there's like a pop or a lot of bruising or whatever happens, and then I worry about my repair too. So it's a little conservative, but I think it's the right thing to do for people.
And what about resuming sexual activity?
I tell people a week, and I tell people be gentle, sort of
take it slow.
Not a whole lot. If you can choose positions that are not, there's not a lot of banging directly on the incision, and people usually get that. Just be mindful, use good judgment.
Right. So, in comparing surgery versus embolization, it seems like they're fairly equivalent on most cases, in most situations. Is one superior to another in terms of improving fertility?
Oh, we do not have great series showing this. I think the bottom line is we don't know. And based on multiple small series, they appear to be pretty close to equivalent. There are definitely, I get a number of people who are nervous about like the X-ray component of the embolization and what that would do, because radiation can hurt sperm, but like, does the 2 or 3 X-rays that they take, is that a high enough dose to hurt the sperm? I don't really know if we have the answer to that question. And the other thing is, for both surgery and embolization, they were both very, we say operator dependent. So people who do a lot more of these tend to like have better outcomes. And so in the studies that have been performed, it's hard to say like, okay, if you do a embolization once a month, are you doing as good of a job as somebody who does 3 or 4 a month? And 3 or 4 a week. And same thing for the microsurgery. So we don't know the answer to that question. There's definitely more data for microsurgery, but there's more studies. There's more studies looking at impact of varicocele on semen analysis and fertility parameters. But does the absence of data mean that it doesn't work as well for the embolization? I don't think so. I just don't think there's not as many.
Yeah. And so basically the decision to choose one versus another is just basically a patient decision about what they potentially feel more comfortable with, having heard what it's like, basically.
Yes. Some people, and everyone's different. Some people are really weirded out by the thought of the embolization for whatever reason. And then you have people who are really, really scared about having surgery.
Mhm.
And, for during COVID, like nobody wanted surgery, and now that's sort of changed.
Right.
So it does tend to be a little bit more, patient preference driven.
So outcomes. What are the outcomes of one or the other or both? What are the expectations for outcomes from this type of procedure to fix a varicocele?
So again, the data for the embolization just is like, it's literally probably 6 or 7 to 1 in terms of the number of published series,
Mhm.
maybe closer to 10. So, but basically, for most people, for about, I say 60 to 70% of people, you will see an improvement in your semen parameters.
Mhm.
Bigger varicoceles get bigger improvements in general.
Mhm.
So if there's bigger dilated veins that you fix, you tend to see like a more dramatic change in the semen parameters.
Mhm.
But we check for sperm. I usually check an updated semen analysis at 3 months. You can also see a little bit more catch up at 6 months, but for about 70% of people, you'll see an improvement in the count, motility, and morphology. And for the bigger ones, I tell people maybe expect like 1.5 time to 2 times, like a doubling somewhere in that area, 1.5 times 2, or to 2 factor increase.
Mhm.
For the smaller ones, I tell them, it's a little bit more to be determined, but like for the grade 2s and the grade 1s. But so it's size plays into it a little bit. But for most people, they improve, not just, and the interesting thing is not just the semen parameters. There's so many studies showing that independent of semen parameters, fixing these can improve pregnancy and live birth rates, which probably plays into like the DNA sort of aspect of things.
So that was my next question. How does that improvement in semen analysis translate into conceiving successfully and having pregnancies?
Yeah, I mean, it just seems like it provides better quality sperm. So, pregnancy rates, it's hard. Pregnancy and live birth rates, it's tricky. There's not as many series showing this,
Mhm.
or sort of quantifying it, just because it's difficult to control for female factors. So female
Right.
age and ovulatory status. But definitely it's been shown to improve pregnancy, live birth rates. Interestingly, for couples that are working with a reproductive and gynecologist,
Mhm.
fixing varicoceles has also been shown to improve outcomes if you're doing intrauterine inseminations or in vitro. So I think that's super interesting, that even if you're doing in vitro, if you're taking the egg and the sperm in the same dish and putting them together, that those sperms still perform better if they're post varicocele repair. So it seems
So,
like you're giving couples better quality sperm.
which kind of speaks to, again, speaking out of turn here, it's probably more than just how fast they swim. It's certainly kind of the quality of the sperm, like you said, at the DNA level, potentially also,
The
because
DNA
otherwise,
and yeah.
yeah, that makes sense. And you had mentioned that you're going to start seeing improvement in semen parameters in 90 days and then again at 6 months. So generally speaking, in terms of successful conception, really if you have a varicocele repair, would you anticipate a delay in trying to conceive for about 3 to 6 months to where that really hits, or not really?
I tell people to start trying.
Okay.
If the couples are timing their intercourse, if they know when the egg is there, if they're using predictor kits or the female partner can tell, I tell people start trying, because even the sperm that are being formed, even the sperm it takes 3 months to see full improvement, because a cycle of sperm production takes 72 days. So we sort of round it up to 3 months,
Mhm.
but even the sperm that are sort of midway through their sort of production cycle, that are midway through the assembly line, those sperm seem to be better. So I tell couples, start right away. If, once you're outside the sort of recovery window, if the egg is there, try.
Got it. Last question about varicoceles, about your surgeon. So you're a guy who gets evaluated for varicocele. Maybe you're seeing a general urologist. Maybe you're seeing an infertility specialist. Are there specific questions you should ask that surgeon or urologist about their experience, about their outcomes? What are the good questions that men should ask before agreeing to varicocele surgery? Not about the surgery itself, but about the person doing the surgery.
So I think for any surgery or any kind of procedure, it's a good idea to ask how many do they do? Is this sort of their niche? For any procedure, you want somebody who is sort of high volume or does a lot of them. And certainly there's going to be things that like there's not a high volume of, but varicocele, you should be able to find somebody who does a lot.
Mm-hmm.
Personally, and this is my own sort of potentially bias, I would not feel comfortable doing a varicocele without in somebody who doesn't have a microscope or that little ultrasound.
Mm-hmm.
I know there are definitely people that sort of try and do them without, and probably have okay outcomes. Maybe they have great outcomes. I don't know, but I was brought up that like that is such a safety sort of check and balance, and for my sort of sleeping good at night and knowing that I'm doing right by my patients, those tools really help me to feel like I'm giving my patients the best that there is to give. So those would be things I would ask. Do you do it with a microscope, and do you have the little ultrasound?
And in terms of experience, you had mentioned before 3 or 4 a week. Is that what is a typical good number? I know there's no probably standard.
That's pretty high.
Uh-huh.
Sorry, that's pretty high. I would say I personally do maybe 6 a month. So I do, and that's pretty. I think that's pretty sort of 70th percentile. There's probably people that perform more, but I think the point is, you don't want somebody like, you want somebody who's skilled in microsurgery, who's not doing, that's sort of like most of what their surgical bulk is either testicular or sort of male genital centric, and they know how to work the microscope.
Perfect. Dr. Samplaski, thank you so much. This has been so very, very helpful and informative. I know the guys will really appreciate it. Before we let you go, I'm going to ask you a question completely unrelated to varicoceles. At least I assume will be unrelated to varicoceles. The name of this podcast is Better Man Clinics. The idea is how to live your best life. You as a very successful person in life, what's the secret to your success? How do you live your best life?
Oh man.
Everyone says that.
I think it is probably the old adage of "to thine own self be true." So figure out the things that make you happy, figure out the things that bring you joy. And because I mean, nobody's going to have a life that's perfect. We all have parts of our life that are sort of more and less palatable, but make space for the things that bring you joy. And I think that's probably it. Like, I'm trying to think what travel for me, like I love to travel. We go on a big vacation every year. It brings me so much joy. I love looking at the pictures from our travels. I love seeing new places. I love Thai food. So like, even though it's not that good for you, we like definitely do Thai every, 2 weeks or so. So find the things that bring you joy and make space for them. Is it cliche? Maybe, but like, I think for me, it served me well.
I think it's one of those timeless pieces of advice that never go out of style. That's for sure. Dr. Samplaski, thank you so much for your time and your insights. And for all of you out there listening and watching, thank you for joining us. And remember our mantra here at Better Man Clinics: your best life is a journey and not a destination. Use every single day to get just a little bit better. We'll see you all next time.